Earlier, I was mentioning the different roles of tinkering with medications, or the experiments we can do to help a patient adjust medication to the best effect. And I think the decisions of whether to alter the oral drugs, levodopa being the short-acting one, but also with the option of being able to add longer-acting therapies such as dopaminergic agonists, represents one way of handling motor fluctuations, especially the kind that can have an intermingling of delayed on and the wearing off phenomena. Now, knowing that the pharmacokinetics of levodopa, immediate release that is, are about 2.5 to 3 hours, it's quite logical to think of ways to give a more extended release by a sustained release formulation, of which there are several available. Unfortunately, these don't behave exactly as their title tells us. Sustained release levodopa also has the same problems of getting out of the stomach, of getting absorbed, of possible interference by protein and amino acid intake. And so by and large, the experience that I've had with using sustained release formulations has been relatively unsatisfactory. You don't get 4 or 5 or 6 hours of effect with currently available products. You have delay in uptake. And I think the most reliable intake of levodopa is with the immediate release form. Sometimes it's necessary to take such doses at intervals closer than 4 hours, 3 hours, 2.5 hours, even 2 hours might be the ideal spacing, as inconvenient as that may be for patients. In order to get the most constant effect of levodopa, sometimes it's necessary to increase the dose. It just so happens that 100 milligrams in the typical 25-100 formulation of carbidopa levodopa achieves a therapeutic blood level, but not for everybody. And so an optimal dose can be 150 or even 200 milligrams per dose, even someone with relatively mild Parkinson's disease, because the efficiency of their GI tract to take it up may be different than other patients you've encountered with mild Parkinson's. Fortunately, the absorption of the drug doesn't seem to change over long periods of time, and so what works today, 2 years from now, is probably going to be effective. But what about the option of the on-demand therapy? In this patient scenario that I talked about earlier, apomorphine injections were used. So the problem of delayed onset of effect is one that can be very frustrating to patients, especially since if they've just forgotten to take a dose, if it's an hour beyond their usual dosing cycle and they're off, the fastest that they're going to get back on is 15 or 20 minutes by oral intake. But they have that option of an on-demand therapy with injection of apomorphine that within 10 minutes in many instances, or certainly 15, they can reliably be back on, in contrast to the problem of taking an oral rescue dose. So I would consider that option for patients to be important to have, even if it's carried around and used only infrequently. It might be a security blanket for being able to safely go out in the world and not worry about safety issues of getting stuck in unfamiliar places. At work, a patient can feel confident that within a few minutes, if they happen to go off, they can be back on at an optimal level. And they know what to expect if they've worked out a titration effect with a drug like apomorphine injections. There's a fairly uniform response that will occur time after time. In addition, the use of medication to block the possible side effects of such therapy, hypotension, nausea, perhaps other side effects, can be largely avoided by using a medication like trimethylbenzamide to prevent such side effects.